Welcome to this explainer. Today, we are going to act as dermatological detectives to solve a really frustrating real-world mystery that plagues literally millions of people: facial redness. If you've ever stared in the mirror at a red, angry, irritated face and felt completely lost about how to fix it, well, you are in exactly the right place. We are going to systematically break down the clinical diagnosis and the targeted treatment of rosacea. Okay, let's dive right in by busting a massive myth straight out of the gate. There is this deeply ingrained assumption out there that any red, bumpy, inflamed facial skin is simply an acne breakout. But, as we'll see through the clinical evidence we're looking at today, jumping to that conclusion can actually lead to totally ineffective and sometimes even harmful skincare choices.
Section 1. The acne misconception. To diagnose our skin correctly and separate fact from fiction, we first really need to understand the true clinical profile of our most common suspect, which is acne vulgaris. Acne actually has a very specific set of characteristics. Morphologically, it's defined by the presence of open and closed comedones, which, is just the fancy medical term for blackheads and whiteheads, along with papules, pustules, nodules, and even cysts. Its pathogenesis, or the way it actually develops in the skin, is driven by specific internal factors. We're talking androgens, excess sebum or oil production, the activity of a bacteria called C. acnes, and dead skin cells clogging the follicle, which is known as follicular hyperkeratinization. So it's an incredibly specific chain reaction. Because its root causes are so specific, acne requires highly targeted treatments to essentially break that chain reaction. The main classes of treatment bring in the heavy hitters, including systemic and topical retinoids, topical benzoyl peroxide, antimicrobials, and systemic hormonal therapies. These are tough treatments, perfectly designed to combat excess sebum and bacteria. But think about it. What happens when you apply these to skin that doesn't actually have acne? Now, here is where our detective work really pays off. Unlike acne, true rosacea typically sneaks up on you in middle age. It is centrally located right on the face, features an erythematous or reddened base with visible blood vessels called telangiectasia, and it often comes with this symptomatic burning or stinging sensation. But the ultimate, absolute clinical differentiator, rosacea is monomorphic with a complete and total absence of comedones. Let me repeat that. If there are no blackheads or whiteheads, it is not acne. Section 2. Diagnosing the 4 rosacea variants. Once we use a solid clinical diagnosis to firmly rule out acne, our investigation shifts. We must identify which of the 4 distinct phases of rosacea we are actually dealing with. Clinical medicine categorizes rosacea into 4 totally unique variants: vascular, inflammatory, ocular, and fumatous. Understanding exactly which variant is present is literally the only way to successfully manage the condition. Let's examine each one. First up is the erythematotelangiectatic. Say that 3 times fast, or we can just call it the vascular variant. This presents with recurrent flushing, a really frustrating burning sensation, and a fixed erythema right in the central part of the face. A hallmark feature here is telangiectasia, which are those visibly dilated blood vessels you can see just under the surface of the skin. Next is papulopustular, or inflammatory rosacea. And wow, this one is the great deceiver. It looks remarkably like an acne breakout, characterized by intermittent pink or red papules and inflammatory pustules. But remember our key detective clue from earlier. There is a complete absence of comedones here. Absolutely no blackheads, no whiteheads whatsoever. Which brings us to a hidden danger that, honestly, so many people overlook: ocular rosacea. It is shockingly common, affecting roughly half of all rosacea patients. So it isn't just about redness on the cheeks, it actively impacts the eyes, ranging from blepharitis and conjunctivitis all the way to much more serious complications like keratitis. Finally, we have the fumatous variant, which we see more commonly in males. This variant is structurally transformative. It results from marked sebaceous gland hyperplasia and fibrosis, so essentially a major overgrowth of oil glands and thickened scar tissue. Visually, it causes hypertrophy and this irregular, almost rubber-like thickening of the skin. While it most famously affects the nose, which is a condition known as rhinophema, it can also impact the cheeks, the forehead, the chin, and even the ears. Section 3. Targeted rosacea treatments. So diagnosis is really just the first step. Once we precisely identify the specific variant on our patient, we can deploy an exact, highly targeted treatment plan.
But before we even get into the specific medical interventions, there are foundational golden rules for every single rosacea patient. Regardless of the variant, all patients absolutely must consistently use sunscreen, and they have to avoid their known triggers. Furthermore, managing expectations is huge here. Patients really must understand and accept that this disease is usually chronic. It's all about long-term management, not a magical overnight cure.
So let's see how the treatment builds based on the variant. For the vascular type, we actually rely on lasers to target the telangiectasia, and alpha agonists or beta blockers to dial down that facial erythema. Conversely, inflammatory rosacea responds to an entirely different arsenal. We use topical antibiotics like metronidazole, azelaic acid, or ivermectin, systemic antibiotics like tetracyclines, and for the really severe cases, isotretinoin. Continuing on to the remaining variants, ocular rosacea requires its very own specific course of topical and systemic antibiotics to really protect the eyes. Meanwhile, the physical structural changes of phimatosis rosacea, like rhinophyma, demand physical interventions. This means surgical remodeling, electrosurgery, or lasers to actually reshape the thickened tissue. Section 4. Other lookalikes, also known as the steroid trap. Because right when you think you've finally solved the case and distinguished rosacea from acne, there's another really sneaky suspect that mimics our previous culprits. Enter perioorificial dermatitis. This presents as a papulopustular eruption accompanied by scaling around the mouth, nose, and eyes. Interestingly, this typically affects young females, and the most common cause is incredibly ironic. It's actually triggered by the use of potent topical corticosteroids, literally the very creams people often apply, hoping to fix their skin irritation. So how do we spot this imposter? First, it may cause an itching or burning sensation. Second, just like rosacea, it completely lacks comedones. But the totally unique clinical identifier here is that it typically spares the vermilion border of the lips. This leaves a very noticeable, completely clear ring of normal skin right around the mouth. The treatment for this condition is quite literally an exercise in patience. Because it's so often steroid-induced, the primary treatment requires a gradual, careful tapering use of those offending topical steroids. You have to literally wean the skin off the product. Medical professionals will only step in with topical and systemic antibiotics for the absolute most severe cases. Section 5, the ultimate takeaway. As we wrap up our medical investigation today, we really have to look at the big picture. Why does getting this clinical diagnosis right actually matter so much? What are the long-term stakes here?
Well, the stakes for your skin are incredibly high. We know for a fact that leaving actual acne untreated can result in permanent scarring. It requires true intervention. However, if you misdiagnose rosacea or periorificial dermatitis as acne, and you blast your sensitive face with harsh acne treatments or strong steroids, you are basically throwing gasoline on a fire. You will actively exacerbate the chronic symptoms and make the inflammation so much worse. Which brings us to a final thought to chew on. What is your redness actually trying to tell you? The right clinical diagnosis is literally the only true map to clear skin. The symptoms on your face are a language. So are you going to keep guessing with random over-the-counter creams, or are you ready to seek a proper clinical diagnosis to finally clear up the confusion? Thanks so much for joining me for this explainer. Keep learning, and I'll catch you next time.